Morning, everybody. Myself, Dr. Tejas. Good morning, everybody. Good morning, everybody. Myself, Dr. Tejas. Today's topic is idiopathic hypertrophic pachymeningitis. My moderator for today is Dr. Kiran. Today, I'll be talking about the definition and classification of idiopathic hypertrophic pachymeningitis. It's epidemiology, etiology, clinical features, the diagnostic workup, the differential diagnosis, the treatment approach, prognosis, and finally, case description. Hypertrophic pachymeningitis is a clinical disorder due to localized or diffuse thickening of cranial or spine. First, it was described by Charcot as a process in which neighboring leptomeninges always suffer as well as become opaque and thick and further gets united to the dura and the cord. The meninges comprises of three layers, mainly the dura mater, arachnoid mater, and the pia mater. The dura mater is the outermost and the thickest of the meninges and is formed by the dense connective tissue closely related to the inner table of the skull. It consists of two layers, periosteal layer and meningeal layer. It compartmentalizes the brain via the falx cerebri and tentorium cerebelli, thus preventing the directional movement of brain within the skull. The other layers are composed of pia mater and arachnoid mater, are thinner, hence they are referred to as leptomeninges. The arachnoid matter lies beneath the dura mater, maintains a barrier between the pia mater and the dura mater, creating a subarachnoid space, which contains cerebral arteries and the CSF. The pia mater is the innermost layer of the meninges. It is adherent to the surface of the brain and spinal cord. It follows the gyri and sulci of the brain. So this is the dura mater with subdural space with containing the venous sinuses, and the arachnoid matter with the arachnoid granulation, the pia mater which follows the sulci and the gyri of the brain. Between the two layers of dura mater, that is periosteal and meningeal layer, is the venous sinuses. Below that is the subdural space, and the arachnoid matter and the pia mater will follow the sulci and the gyri. Numerous pathological processes target the meninges like neoplasms, infections, and autoimmune disorders. The term leptomeningitis indicates that the pia mater or the arachnoid mater are affected, while the pachymeningitis describes the disease of the dura. As the dura mater encases the proximal portion of the cranial nerves, the cavernous sinus, and the optic nerve sheath, it can lead to damage of these structures. In this diagram, you can see in the T2 weighted T1 contrast imaging showing that T1 post contrast imaging showing hyperintensities along the dura mater in the pachymeningeal enhancement, whereas in the leptomeningeal enhancement, the enhancement is following the gyri and the sulci. The types of the hypertrophic pachymeningitis, it is classified into primary and secondary. Primary is idiopathic and secondary because of other causes. The idiopathic hypertrophic pachymeningitis refer to those cases in which culture, serology, and the dural biopsy fail to reveal a causative infection, tumor, or a systemic inflammatory disease. It is classified as cranial or spinal pachymeningitis. There are two types of cranial pachymeningitis based on the location of dural thickening. One affects the paracellular and the cavernous region involving the cavernous sinus, supraclinoid segments of ICA, and the optic nerves. The other one compromises the posterior third of falx cerebri, tentorial, and clival dura mater. The spinal pachymeningitis usually involves the cervical or high thoracic region of the spinal cord. The idiopathic hypertrophic pachymeningitis rarely affects the spine and the skull base. The estimated incidence of idiopathic hypertrophic pachymeningitis is 0.9 per 1 lakh population, and idiopathic hypertrophic pachymeningitis constitutes half of these cases. The age distribution most commonly presents in the middle-aged and the older adults, typically between 40 to 70 years, with slight male predominance. The etiology of the hypertrophic pachymeningitis are as follows. infectious, that is tuberculosis or complication of sinusitis, fungal infections, and syphilis. Inflammatory causes like IgG4 related disease, granulomatous polyangiitis, sarcoidosis, rheumatoid arthritis, hypertrophic pachymeningitis, Sjogren's syndrome, SLE, giant cell arteritis, Behcet syndrome, and relapsing polychondritis. Neoplastic or lymphoma, en-plaque meningioma, histiocytosis, and carcinomatous meningitis. Others are like if there is a previous surgical procedure involving the dura, or because of cerebrospinal fluid hypotension, or certain NSAIDs can also cause pachymeningitis. The clinical features of cranial pachymeningitis are variable. The long-standing headache is the most common symptom. Cranial involvement, most commonly the second cranial nerve is involved, lead to vision loss in one or both eyes, and the seventh cranial nerve may also be involved. Third, fourth, and sixth cranial nerve leads to diplopia and ophthalmoplegia. Other features include intracranial hypertension, ataxia, seizures, and parenchymal manifestations, hemiparesis, tremors, cognitive impairment, and papilledema can occur without visual loss. The headache occurring in hypertrophic pachymeningitis mainly maybe because of inflammation of dura mater or because of increased intracranial pressure. Seizures usually rare, but maybe because of parenchymal edema, which are adjacent to the meningeal inflammation, or certain venous infarction can also lead to seizures. The clinical features of spinal pachymeningitis most commonly causes progressive weakness of limbs, and sensory symptoms and neck pain and back pain are seen. Bowel and bladder involvement are more commonly seen. Lower cranial nerve involvement may be seen, which is maybe particularly 9 and 10 cranial nerves involvement may be seen. The differential diagnosis of hypertrophic pachymeningitis include IgG4 related disease. The key clinical features of IgG4 related disease are multi-organ involvement, most commonly lacrimal and salivary gland, pancreatic biliary tree, and retroperitoneal space. There is diffuse dural thickening, as in idiopathic hypertrophic pachymeningitis. The diagnostic clues for IgG4 related disease is the IgG4 level more than 135 milligrams and more than 10 to 50 IgG4 plus plasma cells per high power field, with storiform fibrosis and obliterative phlebitis may be seen. Previously, with diseases which were thought to be idiopathic hypertrophic pachymeningitis, more than 50% of them are turning out to be IgG4 related disease. Neurosarcoidosis, such storiform fibrosis is whorl-like pattern of fibrosis that are seen in IgG4, whorl-like or whole pattern or interwoven pattern of fibrosis that is. Then neurosarcoidosis, that is cranial palsies and hypothalamic dysfunction may be seen. The imaging findings are also leptomeningeal enhancement, and in CT thorax we can see a hilar lymphadenopathy. And diagnostic clues for neurosarcoidosis include elevated serum ACE levels or CSF ACE levels, and there will be non-caseating granuloma on biopsy. And Vigenous granulomatosis usually causes upper respiratory tract involvement, and pulmonary hemorrhages are seen in Vigenous granulomatosis. Imaging findings, mainly sinusitis with dual enhancement. The diagnostic clues for Vigenous granulomatosis include C-ANCA and PR3 positivity, and necrotizing vasculitis, that is seen in Vigenous granulomatosis. Then lymphoma, these symptoms are seen in lymphoma. There is fever and weight loss. And imaging finding, if you get an FTG PET, it shows a mass lesion with increased FTG intake. And there will be nodular enhancement. And diagnostic clues are CSF cytology for malignant cells can be seen. Atypical lymphocytes can be seen in CSF. Then tuberculous meningitis, fever, night sweats, and meningismus. Imaging findings, mainly the basal meningeal enhancement is seen, but along with pachymeningeal enhancement, there may be leptomeningeal enhancement as well in tuberculous meningitis. The diagnostic clues include CSF lymphocytic pleocytosis, and TB PCR will be positive. In spontaneous intracranial hypotension, that is key clinical features are orthostatic headache and nausea. There will be diffuse neural enhancement, but along with that, there will be brain sagging. And diagnostic clues are mainly low pressure CSF. enhancement. No, no. Yes. No, sir. Pachymeningeal enhancement may also be seen in certain cases. Some cases will have both leptomeningeal and pachymeningeal enhancement, and certain cases will have. Yes. So, CSF IgG4 level will be elevated. In the IgG4 related disease, even the CSF IgG4 level will be elevated. Then Tolosa-Hunt syndrome, there is painful cranial nerve third and sixth nerve palsy. There will be cavernous sinus enhancement. The diagnostic clues include rapid steroid responsiveness. Then N-plaque meningioma. Focal deficits and seizures are seen in N-plaque meningioma. The dural base mass with dural tail, there will be hyperosteotic bone that is seen. And diagnostic clues include biopsy, and the biopsy can be helpful in determining. Then rheumatoid arthritis associated pachymeningitis, which can it will be key clinical features will be joint deformities and rheumatoid nodules. There will be focal dual thickening, cranial more than spinal, and there will be positive rheumatoid factor and anti-CCP antibodies that will be seen. The diagnosis, the the diagnostic workup, mainly the etiological workup of hypertrophic pachymeningitis is mainly by clinical laboratory and imaging workup. The gold standard for hypertrophic pachymeningitis is dural biopsy. Idiopathic hypertrophic pachymeningitis is mainly diagnosed after ruling out the infectious disease and inflammatory and autoimmune diseases and malignancies, uh, especially lymphoma, granulomatous polyangiitis, Virginius granulomatosis. Uh, Most common presentation in hypertrophic pachymeningitis is headache with cranial paralysis, long-standing headache uh, with cranial paralysis. Optic nerve visual blurring will be there. Visual blurring with diplopia, 3, 4, 6 cranial involvement will be seen. Which will be involvement of the cavernous sinus. If it is involving the cavernous sinus, it will cause 3, 4, 6 cranial involvement. If it is affecting the spinal dura mater, then it can lead to weakness, sensory symptoms, and if the posterior aspect of the skull, that is a tentorium cerebelli, if it is affected, and if it is causing the posterior fossa, then it can affect the seventh, eighth, ninth, 10th cranial nerves can be affected. So, and along with that, it can, if the posterior fossa is involved, it can lead to ataxia also. Lower cranial palsies are less common when compared to third, fourth, sixth cranial involvements. Second cranial optic. Uh, Diagnostic workup. First step is it can be both. Secondary, because of increased intracranial pressure can lead to secondary, and the primary can also be called. See, first step, clinical character diagnostic workup. First, we have to clinically characterize what may be the cause for hypertrophic pachymeningitis. The patient is having mainly respiratory involvement like fever, cough. Then we have to suspect tuberculosis or neurosarcoidosis or granulomatous polyangiitis. Granulomatous polyangiitis mainly affects the upper respiratory tract compared to the lower respiratory tract. Then involvement of the salivary gland, lymph nodes, and pancreas. We should think of IgG4 related disease. And if there is a predominant pulmonary, renal, and paranasal sinus involvement, that is upper respiratory tract, and pulmonary hemorrhages are seen, and renal failure are seen, then we should suspect vaginal granulomatosis. Then, if there is hypothalamic involvement, like excessive poly, polydipsia, then we should think of IgG4 related disease, sarcoidosis, or histiocytosis. History of neoplasm, then we should think of meningeal carcinomatosis. Second step includes CSF analysis and neuroimaging. Molecular assays, serologies, and cultures are essential to rule out tuberculosis and syphilis and fungal infections. In CSF, the opening pressure may be elevated in idiopathic hypertrophic pachymeningitis. The cure of CSF in idiopathic hypertrophic pachymeningitis is variable and is not diagnostic. Protein elevation is seen in almost 50% of cases. CSF lymphocytosis may be variably present. A CSF analysis for infection neoplasm should be negative, and CSF metagenomics can also be done to exclude infections. The neuroimaging CT brain shows thickened hyperdense dura, typically involving the tentorium, falx, or the prepontine region, which enhances markedly on contrast. But the imaging of choice is MRI, T1 contrast. Shows a thickened dura appears isointense to hypointense on T1 weighted imaging and hypointense on T2 weighted imaging associated with hyperintense edges. The contrast administration uniform enhancement of thickened meninges. The contrast enhancement is mainly because of increased vascular permeability because of represents dense fibrosis and enhancements test inflammation. Brain parenchymal involvement may be noted in some patients. Like seizures, a patient can have seizures. The occipital lobe enhancement will be extending into the MRI features relevant in differentiating idiopathic hypertrophic pachymeningitis and secondary hypertrophic pachymeningitis is in idiopathic hypertrophic pachymeningitis. Usually, the enhancement will be falcotentorial, involving the falx and the tentorium cerebelli, and medial and basifrontal involvement, followed by frontal and temporal convexities and skull base. Skull base is the least commonly involved. Most commonly involved is falx and tentorium cerebelli. Eiffel by night sign is found in 60% of patients. Sir, Eiffel in night. Yes, sir. Significant improvement in of pachymeningeal enhancement usually occurs only in secondary cases of hypertrophic pachymeningitis. Whereas in idiopathic hypertrophic pachymeningitis, even with the clinical improvement, such same degree of MRI improvement in the reduction of thickening of dura does not occur. So we need not go behind the MRI that if the MRI is not improving, then we need not keep on giving steroids or continuing the immunomodulation therapy in these patients. Neuroimaging. This shows axial post-gadolinium image enhancement with diffuse dural enhancement, including of the cerebri. Falx cerebri is diffusely enhanced. Diffuse enhancement. Sorry. Fox cerebri will between so it separates the yes Fox separates the hemispheres. And so, tentorium scribbling, not seen this. This imaging is showing T1 weighted imaging with cerebral parenchymal involvement. So mild amount of edema is present in the hospital. Eiffel by night sign. This sign has been seen in almost 60% of patients with idiopathic hypertrophic pachymeningitis. Is one of the important signs in differentiating it from idiopathic hypertrophic pachymeningitis from secondary hypertrophic pachymeningitis. This represents the thickened dura in the posterior falx and the tentorium due to fibrosis. It is seen as a central hypodensity in the post-contrast T1 weighted image with enhancing periphery. The central hypodensity denotes fibrosis. The enhancing periphery depicts the areas of active inflammation. So this is the T2 weighted imaging showing hypointense falx cerebri and tentorium cerebelli. And after contrast injection, it is showing contrast enhancement with central hypodensity. The central hypodensity denotes fibrosis, and the peripheral enhancement denotes inflammation that is causing the peripheral enhancement. This is appearing like illuminated tower of illuminated Eiffel Tower at night. Hence, the name is illuminated Eiffel Towers. Vijay. It was described by Vijay. Uh, then the same image in tuberculosis, the secondary hypertrophic pachymeningitis, the Eiffel by night sign is negative in this picture. So that is also helpful in differentiating primary versus secondary idiopathic hypertrophic pachymeningitis. In this picture, sir, there is tentorium cerebelli involved. So enhancement is there, and along with that, falx cerebri and along with convexities are. And sir, yes, sir, falx cerebri and convexities are involved along with tentorium cerebri. These are some examples of secondary hypertrophic pachymeningitis. The first one is of usually secondary hypertrophic pachymeningitis will be more of a focal enhancement than a diffuse enhancement. As in the first picture, which is a granulomatous polyangiitis patient, which is showing focal enhancement of the convexities and also the tentorium cerebelli. And second one is also with the sarcoidosis patient with asymmetric involvement of the left tentorium cerebelli. And the third one is showing enhancement of the cavernous sinus with uh, which is of a IgG4 related disease patient, and along with the and fourth one is of a neurofibromatosis patient, which is showing a isometric thickening involving the left convexities, and Yes. Neurosyphilis, I'm sorry. Neurosyphilis patient. And this is of neurotuberculosis patient showing hypertrophic enhancement of the ura matter. And then this is of uh, so, intracranial hypotension patient with post CSF lumbar puncture showing diffuse enhancement of the pachymeningitis, which is an important differential, which will not cause hypertrophic pachymeningitis, but is a differential for uh, uh, diffuse meningeal enhancement. Then this is of a MRI cervical spine showing diffuse enhanced T1 weighted imaging, T1 contrast imaging showing diffuse enhancement of the extending from the cervical up till the thoracic segment, extending up till the C5 segment with spinal cord compression at the C5 level. There is thickening of the serum IgG4 and CSF IgG4 level, serum IgG4 level. HIV serology, VDRL testing, and galactomannan is checked in immunosuppressed patients, mainly to rule out aspergillosis. Then fourth step is for systemic survey of other organs, including neck, sinus, thorax, and abdomen, and pelvis, that is CT or ultrasound abdomen, for ruling out other differential diagnosis or to look for any other possible biopsy sites. If the systemic survey is negative, we have to perform a whole body PET with 18 FDG CT, which might reveal hypermetabolic lesions which are not observed in conventional imaging. When to consider for biopsy in hypertrophic pachymeningitis, there is no clear-cut indications or guidelines that has been put forth for consideration of biopsy. If the patient worsens clinically, despite treatment, the investigations fail to detect any secondary cause, then we can plan for biopsy to look for the cause. Biopsy is the gold standard for the definitive diagnosis. It shows chronic inflammatory infiltrate with lymphocytic infiltration with few plasma cells and dense fibrous inflammation. This is the lymphocytic infiltration with the dense fibrous infiltration that is seen in biopsy. Sir. This is a magnified image of the same picture, which is showing dense lymphocytic. Sir, dense lymphocytic infiltration with uh, fibrous infiltrations. So this is the overview of the diagnostic workup. Initial evaluation include MRI with contrast and CSF analysis, which includes CSF cytology, flow cytometry, biochemistry, and opening pressure culture for bacteria, mycobacteria, and fungus, PCR and VDRL testing to be done to rule out syphilis. Then etiological investigations include serum IgG4, ANCA, CT, paranasal sinuses, CT thorax, abdominal MRI, and cervical ultrasound, ANA, serum VDRL testing, and rheumatoid factor, HIV serology, galactomannan testing for aspergillosis infection, and long bones radiography and hypophysis survey to be done. So mainly for lymph nodes enlargement, if there is salivary gland enlargement, which can be indicating IgG4 related disease. Then we have to search for biopsy site, that we have to check the systemic survey testing. If no sites are indicative, then we can go for a FDG PET scan before the final decision. So hypertrophic pachymeningitis, we should reasonably exclude causes systemic survey for other sites. If it is positive serum ANCA or biopsy with granulomatous inflammation or necrotizing vasculitis, that is granulomatous polyangiitis. We can go for pulse therapy with methylprednisolone 1 gram per day for 3 days, and followed by prednisolone 1 mg per kg, and cyclophosphamide for 6 months can be given. Initial dose is 500 to 750 mg per meter square. Then biopsy with lymphoplasmacytic infiltration. If there is more than 40% of cells expressing IgG4 with storiform fibrosis and obliterative phlebitis, then it is IgG4 related disease. Can go for prednisolone 0.6 mg per kg, and we should consider rituximab for this patient, which has a proven good role in IgG4 related disease. If biopsy is showing non-caseating granuloma, we should suspect neurosarcoidosis, and prednisolone 1 mg per kg. We should consider pulse therapy with methylprednisolone 1 gram for 3 to 5 days if there is recurrence or severe symptoms. Then, if there is no systemic features or uncertain biopsy, that is idiopathic hypertrophic pachymeningitis, then prednisolone can be started with 1 mg per kg, and we should consider other immunosuppressive agents if there is recurrence. The treatment approaches in idiopathic hypertrophic pachymeningitis, the first line therapy is corticosteroids. High dose corticosteroids are typically the initial treatment. This involves the pulse therapy with intravenous methylprednisolone. After that, we can go for tapering dose of oral prednisolone. The effectiveness is early initiation of steroids has proven better outcomes because it helped in preserving vision and reducing headaches. All idiopathic hypertrophic pachymeningitis, they respond well to steroids. According to a retrospective study conducted by Mayo, sir, secondly, the problem with idiopathic hypertrophic pachymeningitis is when we start to taper the steroids, there will be recurrence of the symptoms once again, sir. Almost all patients will respond. No, sir. I have gone through the. According to a retrospective study conducted by Mayumi et al., the prednisolone dose of less than 20 mg are associated with recurrence in patients with idiopathic hypertrophic pachymeningitis. It was a Japanese study done in 2014. Sir, second line steroids and second line steroid sparing agents. These agents are used to reduce the need for high dose corticosteroids and to maintain remission. The commonly used agents are azathioprine, 2 to 3 mg per kg per day, and cyclophosphamide. The initial dose of 500 to 750 mg per meter square each 4 weeks with dose adjustment according to the lymphocyte nadir, is after 10 to 14 days. Methotrexate can be given up to 20 to 25 mg per week. Then rituximab, 375 mg per meter square, 4 weekly doses. The abnormal dural enhancement may persist despite clinical improvement due to corticosteroids or immunosuppressive therapy. There is no specific set of guidelines for starting. I searched for the these things. I couldn't get any specific guidelines. These are some of the studies which are seen. There is a Smith et al. It is a US study done in 2004. Here, it is a retrospective study. They checked 12 cases. The treatment in these patients, all the 12 patients were on corticosteroids, and the 2 patients were on corticosteroids with methotrexate, and 2 patients were on corticosteroid azathioprine. 7 patients had improvement. Headache and ataxia persisted in 1 each, and 1 had memory dysfunction, and 2 expired. And ma'am, ma'am, The No, not due to the medicine, because of the not sepsis, not sepsis, because of the disease hypertrophic pachymeningitis because of increased intracranial tension. Tejas et al. Done in 2003. There are 20 cases. They examined 20 cases. In 20 patients on corticosteroids, 3 patients other azathioprine, 1 patient on mycophenolate mofetil, and 1 patient on methotrexate. The headache recovered in 13 patients, but not fully in 7 patients. The cranial nerve palsies recovered in all but 3 patients. There was significant difference in pre-treatment and post-treatment scores in these patients. And other study is RICO S in 2003. There were 14 cases, the 13 patients on corticosteroids, 1 patient on azathioprine, and 2 patients underwent surgery. One surgery was optic nerve decompression for um, because there was imminent vision loss suspected, and second one uh, was for spinal decompression that was done with both with skull base and spinal cord involvement was there. 7 patients had relapse of symptoms as the corticosteroid dose was tapered off. In, in one of the patients with azathioprine, like then on the last one is surgical intervention. Surgical decompression may be considered in cases where there is significant mass effect due to dural thickening, leading to compression of brain parenchyma, cranial nerves, or spinal cord. The medical treatment is ineffective in relieving compression symptoms or preventing neurological damage. The decompression of optic nerve is required in rapidly deteriorating vision. The laminectomy with cord decompression may be required in idiopathic hypertrophic spinal pachymeningitis. The idiopathic hypertrophic pachymeningitis frequently progresses if untreated. Although corticosteroid treatment improves majority of patients, the benefit may be temporary and partial. The spontaneous resolution, response to steroids, or lapsing remitting type has all been described in the literature. Coming to the case reports. Case 1, a 52-year-old female with progressive daily headache, hearing impairment, and loss of uh, smell, visual deterioration, and dysphagia for 1 year. She had previously received a brief course of oral prednisolone. On clinical examination, the visual acuity in the left eye was 6 by 12, and she could only perceive light in the right eye. The fundus showed bilateral optic atrophy. In addition, she had right third, fourth, sixth, and bilateral seventh and ninth and 10th cranial nerve palsies. The routine urine analysis, blood, sir, Sturson syndrome, uh, subarachnoid, sub, sub, subarachnoid hemorrhage extending into the routine urine analysis, blood count, and serum chemistry were all normal, except for an elevated erythrocyte sedimentation rate of 55 mm per hour. The serum was negative for rheumatoid factor, ANA, VDRL test, hepatitis B, and anti-DS DNA. The workup for sarcoidosis chest X-ray, serum calcium, and angiotensin converting enzyme were negative. The bone marrow examination and ultrasound scan of the abdomen to exclude a neoplastic and chronic inflammatory process were all normal. The CSF analysis done revealed two lymphocytes and protein of 26 and sugar of 78 milligram per deciliter. The microbiological evaluation of CSF for cryptococcal antigen, VDRL, and culture for acid fast bacilli and fungi yielded no positive results. This was the gadolinium enhanced Stephen weighted imaging showing markedly thickened forks with tentorium cerebelli involvement. The patient underwent a left parieto-occipital craniectomy. The underlying dura was observed to be thickened, gray, and grossly fibrotic. A biopsy was obtained from the right parietal dura mater. The histopathological examination of the meningeal biopsy revealed a dense fibrous tissue infiltrated with plasma cells and lymphocytes. There was no granuloma formation or vasculitis. Specific stains for fungi and acid fast bacilli were also negative in the biopsy specimen. Sir? Left. Left. Uh, all the etiological workup was negative. So suspecting to be idiopathic hypertrophic pachymeningitis. X should yes. 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 There is uh, night unequal publications. Publications. Headache and most of our cranial palsies are completely resolved by 11 months after the initiation of steroid therapy. However, the profound vision loss in the right eye remained unchanged. Optic nerve involvement is uh, common in idiopathic hypertrophic pachymeningitis. Profound so optic neuropathy one can be because of increased intracranial pressure can cause compression of the optic nerve and lead to optic nerve involvement. Sir. Then second one is because of the meningeal involvement itself which is covering the initial few portion of the optic nerve, which can cause optic neuritis. Retrobulbar neuritis can be seen. Veins that are most commonly occluded are venous sinus. Case number two, 38-year-old lady was admitted with chronic headache of 2 years duration. 2 months after the onset of headache, she was investigated elsewhere. CT scan of head had shown tentorial enhancement, and CSF examination had revealed 10 lymphocytes with normal protein and sugar value. She had given outside anti-tuberculous treatment for a period of 9 months, and clinical examination was normal. The investigations for tuberculosis, sarcoidosis, and collagen vascular disease were negative. CT head showed thickened, enhanced tentorial meninges with dilated third and lateral ventricle with normal fourth ventricle, suggesting a aqueductal obstructive hydrocephalus. She was treated with ventriculoperitoneal shunt, after which her headache subsided. It was decided to keep her under follow-up and steroids were not started. But 17 months later, she presented with 2 months history of headache, dysphagia, stiffness of lower limbs, and unsteadiness of gait. On examination, she had bilateral sixth nerve and ninth nerve, 10th nerve, and 12th nerve, 12th cranial nerve palsies, and bilateral pyramidal and cerebellar signs. The cranial MRI, which was done, it showed thickened enhancement of the tentorium and the dura mater, along with cavernous sinus involvement, and the dura of the base of the skull are also involved, extending to the upper spinal canal. Since the spinal cord was compressed and thinned out at the second and third cervical vertebral level, she underwent suboccipital craniectomy with high cervical laminectomy and biopsy of the dura mater. The histopath examination showed dense collagenous tissue with collection of lymphocytes, plasma cells, and few eosinophils and macrophages. There was no evidence of granuloma or vasculitis in this patient. She was treated with 3-day course of methylprednisolone 1 gram per day, followed by maintenance of oral prednisolone 60 mg per day. During this treatment, dysphagia and the ataxia improved in this patient. So, since there was base of the skull enhanced, there was enhancement of the tentorium cerebelli and the dura mater. So, obstruction of the aqueduct. Could be obstruction of the aqueduct because of basal left meningeal. Good morning, everyone. Today we have seen the topic idiopathic hypertrophic pachymeningitis. This is a topic on which there are many controversies. One is whether it is actually idiopathic or not. It is also possible that it could be a localized CNS form of IgG4 related disease. Main reason is that
it is a curious mix of fibrosis and inflammation at the same stage of the disease. Most of the autoinflammatory disorders, autoimmune disorders, have an initial active inflammatory phase, and later they go on into a burnt out or fibrotic state. IgG4 related disease is one disease in which you have a combined inflammatory and fibrotic illness. And histopathological studies of hypertrophic pachymeningitis have shown the same pattern. Most of the studies prior to 2018 are likely combined IgG4 and idiopathic hypertrophic pachymeningitis because widespread IgG4 testing was not available. Another aspect is that CSF IgG4 testing is coming up in a big way, and it is reported to have much higher sensitivity and specificity for IgG4. So, further studies using CSF IgG4 may further reduce the number of truly idiopathic hypertrophic pachymeningitis. Even among our case cohort, the number of truly idiopathic cases has come down in recent years. And many cases which would have been previously labeled so have now received other diagnoses like IgG4 related, ANCA related, Sjogren related pachymeningitis in recent years. So another aspect is about the treatment aspect. There's no high quality evidence available. When we look at the previous case reports, the response to treatment has been dramatic to steroids in the majority of cases, though some were refractory even to the high dose steroids. So, which second line agent to treat depends on the severity of the illness process. So, how fast we need to achieve a response. There are two situations in which we need a rapid treatment response. One is when the disease process is very fast and there is a imminent loss of vision or an imminent risk of permanent neurological deficit. The other is in a person who cannot tolerate even an intermediate course of steroids because they have cataract, glaucoma, old age, infection on giving steroids, or diabetes, hypertension. So patients of this sort need a rapidly acting second line treatment like rituximab or cyclophosphamide. In the other secondary causes, ANCA related requires a rapid response. And multi-system disorders or IgG4 with multi-system involvement require rapid response. So those cases would require cyclophosphamide or rituximab. Among the oral agents, when we look at the recent case reports, there are some reports of methotrexate having a faster response. In one report, they mentioned that with 15 milligram per week, around 2 to 3 months, they were able to taper off the steroids entirely. And based on our experience in other illnesses, probably azathioprine would have the slowest response. So in the absence of high quality evidence, we can use these as some indirect class 4 evidence on how to uh, decide on the second line treatment. Any other questions from you? So in that case, we can conclude this. Thank you.